PCR is actually the blood and OSDRL. Those are two different tests that we test for syphilis. Okay, so those are your two tests for syphilis. So obviously, what do we want it to be? Negative. Okay, Group B strep, we're going to talk about later because we don't test them until later in pregnancy. We don't test them this early because Group B strep is actually a bacteria that I don't want to say most, some women carry all the time. It's there all the time. Okay? Doesn't hurt her a bit, but it's on her cervix. But when the baby comes through, can you see how that can cause a problem for the baby? It can. So if we test her now for it, what are we going to do about it? But it may not even be there when she delivers. So we want to wait till she's about to deliver to actually test her for it. Because, again, what if she's negative now? Well, that doesn't guarantee she's not going to be positive at delivery.
I think I
Probably
was
still having sex.
35 weeks.
Huh?
I think I was tested for 35 weeks.
Around 35, 36 is the date. So why do we wait till 36 weeks? Number one, it's close enough to delivery, especially, but it's just in case somebody does go into labor early. But what if they go into labor at 35 weeks and she hadn't been tested? Then we treat her. We treat her as if she's positive. Okay? So if we haven't tested, we treat like positive because it can't hurt her.
Oh, that happened to me.
But it can hurt the baby if she is positive and we didn't know. Okay? And we'll talk about that a little later. But again, we test about 36 weeks so that, number one, it takes 48 hours for it to grow because it's a culture. So we're not even going to know for 48 hours once we send it to the lab. So then you're talking about close to 37 weeks, right? And then we have to get it to the hospital and make sure that they get results so that they can treat moms who are positive. Okay. Everything else needs to be negative. Of course, blood type and RH, it depends on them. There is no normal, right? We hope she's positive, but we don't have to worry about that blood to her. Okay? Your H and H. Does everybody realize that the H and H depends on where you live? A normal H and H depends on where you live. Did you know that?
I only knew that because you told us.
Okay. So, a normal H and elevation matters. A normal H and H is obtained through the lab, whether it's in the hospital or outside the hospital, by taking the average of clients who came into that lab to have their H and H checked. Did you know that? So an H and H at one hospital might be a little different than an H and H somewhere else. And can you imagine the difference between south and north, or in Louisiana where we were below sea level to go to the mountains? Okay, so the H and H depends on where you live because it's what people in that climate need to survive. So people in climates of higher elevation need more oxygen carrying capacity, so their H and H is going to be higher than those of us who live in the south or lower elevations or below sea level in Louisiana, you know? So again, that's what matters. So try not to ever get tied up on H and H, but you do have to at least recognize abnormal, okay? And so again, you're going to have normal for pre-pregnant, which could be what you see on your prenatals. That's going to be what they drew before she was pregnant, really, because the fetus, she did come in for her prenatals, and she was pregnant, but I say pre-pregnant because, you know, a baby starts out surviving off of an oak sac, just like a chicken, okay? So it survives off of the oak sac till about I have no idea, maybe 2 months, because I'm not ultrasound tech, my sister is, and she tells me these things, but, and it's not important for you to know how long, but it lives off of the oak sac for the first couple of months. It doesn't attach into the uterus till closer to month 2, 3, okay? Maybe even a little longer, so it's not even surviving off of the mother until the placenta attaches and is well established, and then it takes over and the yolk sac is gone. Okay? So again, it's later that it becomes an issue. So when we see a woman in her prenatals and we're taking her normal blood pressure and getting her H&H, it's really in almost a pre-pregnant state. It's before disease kicks in, right? I told y'all I was going to put that in there a few times because pregnancy is a disease. Okay, so it's in her pre-pregnant state. So we always want to go back to what her normal is. Now we know that by month 3, 4, 5, she has extra plasma, so her H&H might look different. And so what we draw when she walks through the door for delivery is her pregnancy state. And why do we draw it? Number one, because we want to know what she has before she delivers. There are only 2 patients who come in for admission who actually get blood put aside for them personally in the lab when they walk in the door. Guess who that is?
Pregnancy.
Labor and delivery
Cardiac.
and cardiac patients who are going for heart surgery. Does that tell you something? What are the risks of losing blood and needing blood? Like right now. I don't want to wait till I need it for there to be blood available for my patient. So the only 2 patients who walk in the door standard for admission who are going to get blood, type and cross, where they have blood waiting for them in the lab, labor and delivery, and someone who's going for heart surgery. Okay? So I want you to put your mind around that. Okay. So, again, you do have to be able to recognize normal values when it comes to H&H, and her pre-pregnant is going to be that first prenatal visit. So her pre-pregnant blood pressure and her pre-pregnant H&H is going to be on her prenatals in that first visit that we're going to compare to. Now, when it comes to identifying blood loss, it's the blood we drew when she walked in to have the baby, and then 24 hours after delivery. Okay? And so, of course, there's also a dynamic in there we're going to talk about in postpartum.
I have a question.
Mm-hmm.
Going back to the prenatal, when you first find out that she's pregnant, and you do hormone test, do you not do drug tests?
Not standardly, because number one, we don't want to order any unnecessary tests, and unless there's a history or a risk factor, we're not gonna. Now, if she shows signs, and if there's a chance, then we're gonna. But as standard prenatals, we do not check for drugs. Okay? She asks how often she needs to be seen if she continues her pregnancy. How do you reply? How often do women come for prenatal visits?
Once a month.
Once a month
Until
usually around 7 months. It's around 7 months. Then it's bi-weekly
and then we do it.
to 36 weeks. And then the last 4 weeks is once a week. Why? Number one, because, well, we want to monitor for delivery, but we also want to monitor for all those other potentials like gestational diabetes,
Blood pressure,
preeclampsia, which we're going to talk about later, and again, any other signs, abnormal signs, as well as we need to make sure that baby's viable.
When do we start coming once a week?
fetal heart tones once a week. What's that?
When do we start coming once a week?
The last 4 weeks, after 36 weeks.
Okay, so
Mm-hmm.
it's once a month until the 7th month, then
Then
bi-weekly.
bi-weekly
20 at
to
28.
36 weeks. And then it's once a week after that. Because your risk factors go up. Okay? Your risk factors go up the closer to delivery. Okay. What do you counsel her on regarding including her mother in her options? Again, we want to encourage her to talk to her mom. Okay? Because this is not just her that's going to be affected, it's also her mom. Knowing her age and risk factors, what dietary instructions must we give her at this time? What do we know about 15-year-olds and what they eat?
Junk.
Junk. Is that going to help that baby at all?
Nope.
So, what do we
Bad.
know that a pregnant woman, how many more calories should a pregnant woman consume during her
Doubling.
pregnancy?
That's double.
360 a day.
340.
Okay. So, so a little bit, not a lot. Not 1,000 calories. We're not feeding two. Like I'm sure you've all heard. You're not eating for two because otherwise you're going to have a weight problem afterwards. Okay? So again, remember she's probably going to go through for the first 4 weeks. Now we have fetal heart tones already. So do you think she's probably about 14, 16 weeks? Because when do we hear fetal heart tones? Around 14 to 16 weeks. Okay, so she's already almost to that point of being too late for termination. So you need to let her know. And so, again, she probably is already going through some of that morning sickness. We're getting closer to the second trimester. You have to know the significance of trimesters and recognize it. Knowing her age and risk factor, we need to make sure she's eating protein. Eating more frequently rather than big meals will be helpful. What about folic acid? What do we know about folic acid? Right. A woman, and so you think a 15-year-old has enough folic acid? Probably not. Is it too late for her already? Kind of. I mean, it kind of is. We actually counsel women to go on folic acid before. Now, are we still going to encourage her to take folic acid? Absolutely. But again, there's a great chance of neural tube defects if a woman has low folic acid when she's pregnant. Okay? And remember, the development of the neural tube and the neurological system is very early in pregnancy. And so that's why it's usually too late by this time to change that. We want her to take prenatal vitamins and we want her to eat right. So we want to make sure she knows. 4 weeks later, Sim Mom returns with her mom. She admitted to her mom she was sexually active, found out and told her she was pregnant, and decided with her mom's blessings they're going to keep the baby, and that the father's out of the picture. Okay, so she kicked him to the curb. What anticipatory assessment must be done at this time?
STDs.
Yeah, psychosocial. So we need to see, does she have any needs that, this mom, remember, has 2 younger kids and is probably now going to take over with another child. So we need to make sure the resources and support are there. We want to give her what she needs, as well as the dynamics of, okay, now we have to worry about school. She's probably still in school. We want to make sure she stays in school. All of those things, we need to make sure that everything's in place and she has a good support system and that we're meeting her where she's at, okay? And not being judgmental. She's 16 weeks today. What topics are important to educate the patient about during the pregnancy? We kind of talked about things that already happened. We kind of went over things at 16 weeks. She's going into her getting close. We're now starting to get movement. She may be having some having to go to the bathroom more often. Again, we might be having some constipation, motility issues. We want to talk about the family dynamics and does she have any special considerations based on her age and history and family dynamics. And obviously, you know, yeah, there's a lot of things to consider, right? Are there any barriers for her? And if so, what are they? What are some barriers to this 15-year-old?
Kind of like you said earlier, I feel like school.
School, job, who's paying for this? You know, does she have insurance? Is it going to be covered by, is the pregnancy going to be covered by her mom's insurance? All of those things have to be considered. Transportation to the doctor, right. Her mom might have a job and not be able to get off work and, you know, now we have another mouth to feed and, you know, the whole dynamics of that. And so we want to make sure that we're looking into that. So at our 28-week visit, it's a routine visit. What blood work are we going to draw at 28 weeks? Again, we kind of talked about that already because this is when we're going to do her RH, if she's RH negative. Okay? Not quite time to do the diabetes testing, but we're going to also do fetal heart tones at this visit. We want to also start talking about 28 weeks. Now, she's also at risk for preeclampsia now. Once the placenta takes over, guys, now she's at risk for preeclampsia, okay? And so we need to start talking about signs and symptoms of preeclampsia. The other thing we need to talk about is the triple screen, which was probably done early on. And what's the triple screen? It actually is a blood test that we do to pick up on birth defects. It's real high sensitivity to Down syndrome. Okay, it's done early in pregnancy. If it's done too late, then you're going to have false positives. You do not have to have it done. Okay, you're not going to be tested on the triple test, just so you know. I'm just kind of giving you a heads up because you might see that. So, but again, it gives women options of whether or not they would want to terminate if there's a birth defect. Okay, you don't have to have it drawn because if you're not going to do anything anyway, then they're going to say no. Okay, but about 28 weeks now, we're going to do an ultrasound to check for her confirmative. Probably at 16 weeks, they would have done the ultrasound to confirm the date. Because again, remember she had some irregular periods, okay? Her due date might have changed once they did the ultrasound at 16 weeks. So, her results are normal and her blood type's RH, A negative. Again, what is she gonna get? Rodam. So now we're gonna make sure she gets Rodam. Because again, that big daddy, we probably don't know his blood type at all, okay? So, you ask her if she started to think about delivery, and she says she does not have any ideas about what to anticipate and how to get information on, other than her friends keep telling her how much pain she'll be in. How do you reply to that? Birthing classes. So we want to get her involved. You know, her support system are those kids at school who have no idea. So even though she may or may not feel comfortable with other women who are older, we want her to get the right information and know. Now's the time we can start talking to her about epidural options and other pain options during her delivery, okay? So we also want to make sure she knows with knowledge, it is painful. It is. Giving birth is painful. But again, we have lots of other options now that are very, very safe when they're in labor. Okay? So, before she leaves, she expresses her anxiety about how she will know she's in labor. So let's talk about true signs and false signs of labor again. You might see this one day. Okay? So what are false signs of labor? Braxton Hicks contractions. How do you know the difference between a Braxton Hicks and a real
They
contraction.
go away when you relax.
They feel the same and they can both happen every 5 minutes. I know. So what's the difference?
The pain.
Your
maybe? Does it
dilation.
get worse?
Dilation. That is the only difference. And will she know? Can she check herself? No. So what do we want her to tell? What do we want to tell her?
To relax. To your
When
diet.
you're having contractions, turn on your left side,
Drink plenty of fluids.
drink plenty of fluids, because there are two things that really are the culprit for preterm labor. Two things.
Dehydration.
Dehydration, infection. Those two things are going to cause preterm labor. We know that. Now, some women just will have preterm labor without those things. Okay? But the first thing we do when we have somebody in, we think we're in preterm labor, is we do a urine and check for a UTI and dehydration. And we give them IV fluids. That's what we do. And if the contractions stop, then
It was Braxton.
we know that it was not real labor. Now, does that mean she could have had cervical change from it? Absolutely. You can have cervical change even though your contractions are from dehydration and infection. Okay, but if they stop, then we know you weren't supposed to be in labor, and we're going to try to stop them if you're too early. Because again, the baby's safer in utero than outside to have to mature. Okay? So, we're going to tell her, drink lots of water, and of course I love it. So, I'm a water drinker, and whenever I ask people, how much water? Oh, a lot. I drink a lot of water. How many bottles? 3?
That's not a lot.
Guys, you should be drinking a gallon of water a day. And that's if you don't drink any caffeine. Because for every cup of caffeine, that's another bottle of water you need to drink. Plus the gallon. There you go. We are all dehydrated. We are. But, again, we have to make sure that, especially in pregnancy, that they stay hydrated. So we have to be clear. Now, should they drink more than a gallon a day? Yeah, probably. Because they're drinking for 2. So we want to make sure they're well hydrated. And they have an incubator. They're going to lose fluid from their incubator. Okay? So that is really the biggest thing. What are other signs of labor? Discharge, vaginal discharge. A woman should not have vaginal discharge during pregnancy.
That's a true sign?
The gush of fluid.
No.
That's a false.
No, it's a true sign. I mean, it means they need to be checked. Okay, because as the cervix dilates, you're going to lose that mucus. Okay, and so that is you want to be checked. That would be something that you need to have checked. Okay, so we want to make sure she knows that. Okay. What's that?
I was just reading.
Go ahead.
She said
What is-
abdominal pain.
Abdominal pain. And so again, abdominal pain would be a false labor sign, but truly, now some of the other things, that's not necessarily, but what if she starts having vomiting all of a sudden? Again, it doesn't mean she's in labor, but we want to make sure she comes in. But, I mean, that's not going to be a sign. Truly, the difference between true and false labor is cervical change.
Could bleeding be a sign?
What's that?
Bleeding?
Bleeding could be, and they need to come in, but we're not going to necessarily deliver somebody right now because they're bleeding. But again, bleeding is something they need to come in for. Okay?
So they need to come in for both.
They need to come in for both, correct. So, and really, they need to come in. So if the baby quits moving, they need to come in. You know, if they need to come in to be checked because there's no way. You know, I feel really bad because working in labor and delivery very often, these women come in because they're having contractions and the nurse is like, they're here again. Well, why not? I mean, you know, like, I would want to know too, because we don't go around checking ourselves, you know? You can't check cervical dilatation, and truly, that's the difference. The problem is that a lot of women want to be in labor, and I actually had a patient who knew how to make labor contractions on the monitor.
Ah!
She did. She kept pushing on the monitor because it's just pressure, and she would make that pre-contraction. Oh my gosh, she was having some amazing contractions. She didn't know that it didn't matter if she wasn't dilated. She still went home and had an IV. So, oh well. Okay, she returns at 36 weeks. What culture should we anticipate? Group B strep. And I already told you why, and you know, so again, if she's positive at delivery, we're really treating her for the baby. Okay? So there's kind of a back and forth. If someone's scheduled for a C-section, nowadays the doctors aren't even testing for group B strep. Because remember, if the baby doesn't come through there, then he's not going to get exposed. She's not going to get exposed to the group B strep. So there's still kind of that back and forth of, do we test, do we not test? Well, my problem is what if her water breaks? Before she was scheduled for a C-section. Now there's a potential for exposure because that bag's no longer there to protect the baby. Are you with me? So again, we're really protecting the baby from that group B strep exposure. So just keep that in mind. After her weekly visit, she's now 40 weeks gestational. She's been having some pain in her abdomen. That is a regular after vaginal exam that reveals that she is still closed thick high. The doctors now tell her that she has a gynecoid pelvis. Okay, so guys, it's not on your test, but you do need to be familiar with the type of pelvis and what that means for delivery. So women have 4 different type of pelvises, and based on your pelvis, it kind of really tells whether or not you'll be able to deliver vaginally. Okay? Because if it's flat, a baby's not going to fit through. Okay? If it's open and round, a baby will fit through. So, again, you do want to be familiar with that. Okay? How will we determine if she's in true or false labor? Obviously through cervical change. Now again, because she's closed right now, does that mean she's not in labor? Mm-mm. No, it doesn't. Because she's closed, thick, high, that's usually where you start. But it may be the beginning of labor, so we really need to watch her. So normal labor progresses after 5 centimeters, 1 centimeter an hour. Before that, it's all about change. So you want to watch somebody for an hour and recheck them. Now the problem also is my 1 centimeter might be somebody else's 2 centimeters. You get it?
Mm-hmm.
My fingers might be smaller than somebody else's or bigger. So it has to be the same person checking them, and it really doesn't matter until they're fully dilated, having no cervix left, as to what they are, as long as they're making progress. Okay, so as long as she's progressing, that's what labor is all about, until she's 4 centimeters. So the in-between, what you call it, doesn't matter necessarily, and if you ever become a labor and delivery nurse, you just learn. Okay, so I used to have a thing that actually showed the centimeters. I would pass it around, and so you get an idea for it, but it's not something you, as a student, needs to know, other than progression. You start at 0 and go to 10. 10 means complete. What's that?
Your little paper that you put up on the thing from Cheerio to a bagel.
To bagel? I've never heard that. There you go. It's from Cheerio to bagel, and you're right. And 10 centimeters means you can't feel cervix at all. Like you can feel all the way around the baby's head and there's no cervix left.
That's cool.
It is very cool. It is very
So
cool.
how do you find out what kind of pelvis they have?
The doctor does, you don't. Okay,
What
so
do
that's
they
not
do?
something you would need. He'll make
He can tell.
suggestions. They will still allow somebody to try to deliver vaginally, but usually they give them forewarning. Chances are you're going to be a C-section. And guys, I always ask moms when they come into labor, how did your mom deliver?
Yeah.
And do you take after your mom or your dad? And it's usually a giveaway as to whether or not it's going to turn out to be a C-section. I don't tell them that because, I don't want to pop their bubble. So, and again, you have to know if it's favorable or not because I'm not testing on it. I'm not going through it. But please take a few minutes to look over the 4 types. Ultrasound is done and the fetal position is identified as cephalic, vertical lie, and the attitude is flexion. Very important information here. Okay, so we're going to take a few minutes to go over it. Remember, delivery depends on not only mom's pelvis as to the ability for the baby to come out, but the attitude, lie, and presentation of the baby. What is cephalic? The head. So that means the head is in mom's pelvis when a baby is cephalic. Okay? Now, does that always necessarily guarantee that the baby is going to have a good, easy time delivering? No, because it depends on if the baby is faced towards mom's anterior or posterior of her pelvis. Okay? So we actually, when I'm doing a vaginal exam, I'm feeling suture lines and feeling as to what is presenting. And so what I'm hoping is that the occipital bone of the baby is what I feel, because that means that the baby has flexed. And the flexion is the attitude. Okay? A baby can either be extended or flexed. What do I want? Flexed. Because a baby that is extended, do you think it's going to come out without breaking the neck? No. Okay? And so, again, if that baby hasn't flexed, then we have a problem if the baby is engaged. So now you have another term we have to talk about. Engagement is how far down the presenting part is to mom's pelvic bone in relationship to the ischial spines. Okay? I used to have a pelvis that I brought to class, and because I'm all about showing. It is in your book so you can see. The ischial spines are the point on mom's pelvis where it flares, that point. Okay? Where it comes down and there's that little point. That's the ischial spines of the pelvis. When the baby's presenting part, whatever it is, hopefully it's cephalic, gets to those ischial spines, she is at 0 station. 0 station. If it is 1 centimeter above those ischial spines, she's a -1. It goes all the way to -3 before we call ballotable. So think of a crawfish, like it takes off. Ballotable is when I go in, if that baby's head is movable, it's ballotable. B-O-L-L, I don't know, ballotable. I'm really bad at spelling guys. I'm going to tell you right now. Yeah, I have my doctorate degree, but thank God for computers. B-A-L-L-O-T.
B-A-L-L-O-T-T-E-M-E-N-T.
That's ballotment.
So the status of these.
Ballot, right. Put a table at the end. Ballotable, A-B-L-E. Okay? Ballottabale. I have to see things to be able to spell it.
That's a negative. Is the engagement attitude also?
So, no. The attitude is the baby's relationship to mom's pelvis. So, yeah, it kind of is. But when you think about attitude, you think about how the baby is in there. The position is the baby's relationship to mom's pelvis. The attitude is the baby's position, is the baby's, no, the attitude is the baby, how the baby is in relation, you know, whether it's flexed or extended. Its relationship to itself. Attitude is the baby's relationship to itself. Okay? Position is the baby's relationship to mom. Okay? And then the lie is whether or not it's also the relationship to mom. So it's either vertical or horizontal. Okay? Because a baby can be horizontal in mom's pelvis. Hopefully not when she's 9 months. Okay? Because that's a C-section. So, again, the attitude is the baby's position to in relationship to itself. So you can have flexion or extension. Okay?
And extension's bad.
Extension's bad. Right. So this baby's cephalic, vertical lie with flexion. What does that mean?
She's good.
That's good. That means the baby's in the right position for delivery. Now, is that necessarily going to be the case if she delivers in a week?
Nope.
No.
It changes all
But
the
it
time.
doesn't change as much once we get to 10 months because the baby can't move.
Yeah.
Okay, once we get to term. Because y'all know pregnancy's really 10 months, not 9.
Yeah.
So once she gets to 40 weeks, usually it doesn't move. So if it's breech,
You have to have a C-section.
then we have to have a C-section usually. Sometimes they will do an external version where they try to turn the baby. But if it's there, it's usually there for a reason. So guess what usually happens? It flips back. And let me tell you what sometimes happens.
Cord.
Yeah, we end up having a cord accident and a dead baby afterwards. It happens. So those are the risks that we take. Or a ruptured uterus, because we're doing a lot of manipulation. Okay?
I'm like, take it.
So she's in a good position. However, we have to remember that it also depends on which way the baby's facing. Has anybody heard of sunny side up?
You know, my baby
When a baby's delivered sunny side up, what does that mean? Do you know?
face comes
Face
out
down.
hard.
The face is facing up. Well, guess what the problem is? Hard head, hard spine. It doesn't give. As opposed to where the face is coming through, on top of the fact that the baby goes down and up, so it's a lot harder for the baby to go down and up for delivery. Okay? So we want the baby to be ROA. That is the best position for delivery. Okay? What does that mean? The occipital bone, the O, is the baby's part that is coming out first. We want the occipital bone to come out first. Okay? What are our other choices? The forehead. Okay? The sacrum, S, that's breech. So it's R, S, face, presentation. So the occipital bone is what we want to come out first. That means that the baby flexed and has a good attitude, right? So the attitude is flexion. That the occipital bone, ROA, is facing the right side, okay, of mom's anterior pelvis. So imagine a pelvis, okay? The pelvis, baby's flexed, coming out this way. You with me? ROA is the best position for the baby.
So right side, occipital, interior.
Right. The reason I'm spending so much time on this is it's that important. Okay? Now, but why does it matter prior to delivery? Because when I'm putting the fetal monitor on this patient, I need to know which way the baby's facing to know where I'm going to get fetal heart tones. Okay? So now we're going to talk about Leopold's maneuver. So who wants to volunteer? Anybody want to volunteer? Come on up. So, we are doing Leopold on stem mom. You can go on that side. Are you right hand or left hand? Right hand. Then come on this side. I'll switch sides. Okay. So, thank you. So, we're doing Leopold. Okay? So, what we're doing is we're trying to figure out where the baby is facing based on feeling parts of the baby. Okay? So we're going to start by taking my hands and we're going to move back and forth. Okay? And so what you're trying to feel, and I want you to imagine this, a back. So can you tell me which side the back is on? Okay? So you're feeling harder over here than on that side. Really feel. Okay, so let me feel real quick because I haven't even, it's kind of different on a simulation, Mom. Now, I do want to make sure where the fundus is, okay? This is the fundus, okay? And really, I want to make sure it's head down. So I'm actually in labor, going to feel for a head by taking right above her pelvis, right there. And I'm trying to feel to see if there's a head, and I'm doing it that hard, okay? Can you feel a head? Okay, and it should be round, right? And eyes, you know, like I'm trying to figure out, okay, do I have a butt up here? Do I have a butt down there? And I'm trying to figure it out. But usually, I know, on the real thing. So, but you can really want to feel to see if there's a head down there. I'm hoping, because I didn't look. Maybe she's tricking me. So,
This,
and then,
this stuff comes around a bit also, I'm trying to feel. And that could be the big tissue, I don't know.
you know what? I do think that,
Might be the head, right, or this is the head.
so I think she.
Hey, learning experience.
It is, because this is definitely a head. I can't tell here. So, my baby is breech or sacrum, or it could actually be a footling breech, where it's the feet coming out instead of the butt. And that matters too. Okay? So I do think it's breech. So I do think that the back's over here, we're going to say it is, because I really, yeah, there's not enough parts here to be able to tell.
That's just room.
Right. And so you're going to get fetal heart tones the closest to the heart. Okay, and it's usually on the baby's back. Now, if I have doubts, let's say I do think it's breech, this is the head, and I can't feel that. Like I can't tell. Then where's the back? On mom's back. And I can't get to that. So then I'm going to go opposite the back because it's ultrasound waves coming up. Okay? But we're going to say the back is right here. Okay? So the back's here. And just for your sake, we're going to say the sacrum's down. Okay? So it's the sacrum, their butt, at the bottom, that is facing right or left of mom's pelvis. Right? Anterior or posterior?
Towards even her posterior.
So if the back is here and the sacrum's here,
The mom
anterior, so it's RSA. Y'all with me?
How do you
So
know
why
if
does
it's
it
right or
matter?
left?
Huh?
How do you know if it's right or left?
Because if I can feel it back here,
That means it's on the right
then I
side.
know that the butt's over here,
Okay.
facing over here.
Okay.
Wouldn't
Okay.
that be on the left side?
left side.
It's left, sorry, it is left, sorry, mom's left, because I'm on this side. Mom's left, so it's left S sacrum anterior, LSA.
So we want our way, so in other words, we want all way.
Right,
So
so we
her
really
right
want
away, you
that,
mean for mom, not our way.
right, it's mom's pelvis,
Okay.
not how you're facing
Okay.
it. Okay? It's mom's pelvis. So it's the baby's, the relationship of the baby to mom's pelvis. So the left sacrum anterior is what's showing. So where are you going to put fetal heart tones? Where are you going to get fetal heart tones?
On top.
I have left, I say.
Where's the heart? Think about the baby's heart. Right here. Her left upper abdomen is where you're going to get fetal heart tones.
So putting those for the monitor, I would put one here and then the other one, am I still trying to leave
So,
it just to read for the actual
One,
picture?
right. One is for fetal heart tones, and that we want on the baby. Contractions are going to be wherever you can get a good reading on the uterine wall. Most of the time, contractions really should be felt at the top, okay? So, but because we have to put this up here, we might have to adjust it, but for the most part, you might even have to put it over here, because we need to feel that tensing of the uterus, okay? And we're gonna go in detail with fetal heart tones. So because you volunteered, I have a bag over there with some candy, so you go, or some, well, there's some other stuff in there. There's some other stuff in there, so you go take. So, I know we are very motivated by being free stuff, so I make sure that I bring free stuff to class. You're gonna get a question on fetal position in relationship to where you're getting fetal heart tones. Okay? Because it's that important, because we have to know where to get fetal heart tones. Now, why must we know that it's fetal heart tones in the abdomen? Because we might be getting mom's heart rate on the monitor, because again, she has an artery that runs behind her uterus. So that's why we're going to put a pulse ox on her, so we can differentiate between mom and baby's heart rate. Okay?
Shouldn't the babies be alive anymore?
A
normal.
mom with infection might have 120 heart rate.
I didn't think about that.
Right, I know, and we don't. So, again, you also have to know normal fetal heart tones, which are higher in early pregnancy. They do go down a little bit the closer to delivery. And we're gonna go into that when I do, because we're gonna do, fetal monitoring in a little bit. Okay, so she presented to labor and delivery 2 days ago. Now, we're gonna go over, because I can't remember if I do GTPAL anywhere else. So I'm gonna talk about that real quick. Gravida is how many pregnancies you have had. How many times you've been pregnant?
Gravida.
Gravida. G. Okay. Hera is how many, I want to make sure, because I don't have it in front of me. Hera is how many deliveries you have had. Okay?
Does that reach 20 weeks greater than
Term is when it has
37 weeks.
37 weeks, right. Yes, so I understand your question, right. If a pregnancy doesn't go to 20 weeks, viability, then it wasn't a delivery. Does that make sense?
Yeah.
So it's really how many deliveries you've had.
Okay, so what's her period?
Okay.
That's deliveries?
Okay, so gravida is the number of pregnancies you've had. Para is the number of live births, in other words. Okay, so if a baby is born not live, okay, of course if it ended in a birth, or pregnancies that ended in a birth, okay, in other words, deliveries. How many deliveries have you had? A delivery does not include an abortion. Okay?
So how many deliveries goes over what?
The para. It's how many pregnancies you've had. How many times you've been pregnant.
Page 150 of the book.
Yes. Term is babies that have gone to 36 weeks. Is a term pregnancy. Well, of over 36 weeks. So 36 plus 1, okay, it's anything over, well, actually, yes, 37, because it's into the next. It's after 36 weeks. So it's 37 and above. Very good.
It says 36 weeks, 6 days.
And 6 days, right. Okay. Preterm is any from 20 to 30 to 36.6 weeks. Okay? Is preterm.
20 to 36 weeks?
Yeah, before 37 weeks. Any baby that was born before 37 weeks, but after 20 weeks. Because remember, 20 weeks, anything before 20 weeks is considered an abortion, whether it's a spontaneous or elective. So an abortion is an abortion no matter what. And that is any baby that is born before, before 20 weeks. That doesn't make it to 20 weeks. Living children, okay, or how many children are living, really it's how many children are born alive. Okay, there is some controversy as to, let's say a baby dies at 2, again, do you count that baby or not? And so again, I promise it's not going to be on your test question because that gets real complicated and there's kind of a gray area to that. Because most doctors will ask how many living children do you have, and it is how many children are still alive at the time. Okay? But truly, it's really supposed to be how many children were born alive. Okay? And so you can see how that can be a gray area. So that won't be in a scenario that you were tested on. Okay? Are you with me?
So on para, is that just like deliveries period or only live births, like if they have like a stillborn?
If they have a stillborn, then it's still a para.
Mine says live birth.
Right, but it also goes into or pregnancies that ended in a birth. Okay, so it's a delivery versus a D&C.
Okay.
Okay, it's a delivery versus a D&C. So in the case of twins, how many pairs do you have? 2. So you could be a gravida 1, para 2 if you had twins.
Yeah, because they're counted individually.
Right. As 1. Very good. So you see how that can get real complicated. So, but it's how many babies you have given birth to.
That's what para is?
Para.
How many babies?
Yeah.
Para or
essentially, how many
para?
deliveries you've had. Okay?
Even with the twin thing? Oh, obviously you're delivering too. Okay, never mind. I confused myself.
Okay. Important question, guys. Do some studying. If you have any questions, let me know. That is going to be the EDD and the GTPAL is also going to be one of your sessions. In fact, right before Friday at your rodeo.
Oh,
Okay?
cool.
It's a whole session just on that.
Okay, so is para and parity the same thing?
Yes.
Okay, I'm confused.
Parity is
the ATI book says
Are you
that
on
it
page
has to be,
15?
yes,
Okay.
greater than 20 weeks past
Right,
period.
right, because,
Not that it's delivered.
well, anything before 20 weeks is not really, they may come out vaginally, but it's not really a delivery. Are you with me? Anything before 20 weeks, even if you deliver, we still call it products of conception. No, it's not really a baby. Yeah, we are. Do you get it?
No.
It's not a baby
Uh-huh.
until 20 weeks.
Right.
So just because you actually delivered it vaginally, rather than had a DNC, it's not a baby. So it's not counted as a para.
They're not born.
And the L stands for living children.
Living children.
And the A is abortions,
This says-
miscarriages.
Okay, parency is number of pregnancies in which the fetus or fetuses reach 20 weeks of pregnancy, not the number of fetuses. Parency is not affected whether the fetus is born, stillborn, or alive.
Right.
Stillborn would be like forever.
So I'm going to suggest, mostly because, guys, sometimes y'all learn from each other better than from me. So get with someone. If you're still having questions, let's sit down and do some scenarios. Because again, I want you to think of a pregnancy prior to 20 weeks as just products of conception.
My thing is, so if they're, I don't know.
I think if you step back, you'll understand. So we're going to take a break, guys. Let's come back at 10 after.
They have no, most of the time, if you're before 20 weeks, they're not.